Great, let's bring up that splash screen again. Thank you. Okay, for those of you who are just coming in and joining us at the start of this evening's keynote, we're just going to give this another minute or so, and then we'll start with the formal introductions as people continue to roll in. I want to remind everybody who's here that we are encouraging questions and comments, and we have built in a pretty generous amount of time into this evening's program for questions, comments, or otherwise. So we'll be actively watching the chat and trying to bring in as many of your points as well. So feel free to write throughout, and we'll have an eye on them. We're at 8:02. We'll spend just a minute more or so, and then we'll get going. Always thought we should add some entry music to these things, Jordan. I'm not sure what that entry music would be for Professor Sista. Maybe it would be Rage Against the Machine or something like that, as we're trying to change paradigms in PE. All right, well, here we go. Hello, everyone. My name is Zeev Haskal. I'm a professor of radiology in the Interventional Radiology Division, Vice Chair of Career Development in the Department of Radiology and Medical Imaging at University of Virginia. Welcome to today's latest installment in our ongoing multi-year Radiology Department Keynote Lecture Series. Tonight is a great one. I am very excited to have the world-renowned Professor Akhilesh Sista, who is Professor and Vice Chair of Radiology and Interventional Radiologist at the Weill Cornell Medical College in downtown New York City. Professor Sista has published nearly 100 papers, over 250 lectures. He is the national PI of the NIH-funded PE-TRACT trial of catheter-directed therapy of PE. It's really what we're going to hear about at the core of the lecture tonight. In addition to that, he's run a number of essential trials in this area. He's co-chaired the AHA scientific statement on interventional therapy for PE and on the steering committee for the C-TRACT trial as well, which is the NHLBI study. He's also had a number of prestigious awards. Just one of them was just a few years ago, the Society of Vascular Medicine's Mark Krieger Prize for Research Excellence. And of course, he's an honorary fellow at multiple societies. So we are very excited to have you here. And also, I want to acknowledge up front that my co-moderator and co-discussant tonight is Professor Andrew Michalik. Andrew is an associate professor in the Internal Medicine Division, importantly, the medical director of the Pulmonary Hypertension Service at UVA, and the associate medical director of our now long-standing and very successful and research-driven PERT program as well. So I'm excited and grateful that you're joining us as well. And with that, the screen's yours, Aki. Please share. We're excited you're here.
All right. Well, can everybody hear me? Great. Steve, thank you for that fabulous introduction. Much more than I've actually accomplished. And it's really an honor and a pleasure to speak to the UVA community about the PE-TRACT trial. I saw on the participant list that there were many friends there. So I look forward to hearing from you either through the chat or otherwise after or during and after this this didactic part of this hour. So really what this talk is just kind of maybe rewinding the clock a bit and looking back at why PE-TRACT was ultimately funded and is being conducted. And I think the story for how we came here is almost as interesting as the trial itself. Here are my disclosures. So before we dive into PE-TRACT, there's quite a bit of background I think that could be useful for us to just be on the same page about, given that we're a multidisciplinary group here. Beginning with the fact that PE is no question a big deal. 900,000 venous thromboembolic events per year that encompasses both DVT and PE. This estimate for number of deaths is approximate and hard to really pinpoint, but this is what we're circling around. It should be noted that outside of stroke and MI. It is the third most common cause of cardiovascular death. If you put an echocardiogram on every single patient, maybe even up to 50% may have some evidence of right ventricular dysfunction at some point during their PE. If you were to look at patients either through a CT angiography or VQ scanning, in the months following the acute PE, a third of these patients will actually have residual thrombus in their pulmonary artery. And what we're noticing is actually exercise capacity may be diminished in a large minority of these patients as well. So all of this can get interventionalists excited about removing this clot and doing so frequently. But there are a couple things that we should keep in mind before getting this excited. The first is that most patients have low risk PEs. So probably 60% of patients will present with a low risk PE. And there really isn't any evidence at all that they need anything more than anticoagulants. Submassive PE which will be really the majority of this talk, carries significant controversy. And that's really the reason why we need the randomized trials that are going on. And across the spectrum of submassive PE, there's a wide variety of opinions about how aggressive we should be. So we should talk about definitions so we're all on the same page. Anytime we see something like this, our eyes get big and we say this must be a massive PE. However, while it probably is with this amount of thrombus burden, it is not necessarily a massive PE. What is a massive PE? Well, it came from the American Heart Association definitions in 2011. A massive PE is a PE associated with hypotension. So systemic hypotension as defined by a systolic blood pressure of less than 90 millimeters of mercury for greater than 15 minutes. Also in this definition can sometimes include a greater than 40 millimeter of mercury drop in blood pressure, or requiring some sort of inotropic or vasopressive support to maintain a blood pressure. In contrast, submassive PE, the patient is technically normotensive, but their RV has some element of dysfunction, either detected by imaging or through biomarkers or labs. And low-risk PE has neither of these features. It should be noted that the European Society of Cardiology has their own version of risk stratification for pulmonary embolism. High-risk PE is the same as massive PE. Intermediate risk PE, without getting into too many details, is the general category of submassive PE. And they put some granularity around whether you have both cardiac biomarkers and imaging positive versus one or neither. And then this idea of a PESI class, pulmonary embolism severity index, should be either greater than 1 if the simplified version is being used, or at this higher end of the classes, in order to qualify for an intermediate risk PE. And then a low risk PE is just what it would be for the American Heart Association. But so I will probably use submassive PE and intermediate risk PE interchangeably throughout the talk. This is the PESI score. And what you can see is that the simplified version is what most of us have used. It has been validated, and it kind of has distilled the PESI score into some of the more important measures in terms of 30-day mortality and 30-day outcomes. And those happen to be age, cancer, chronic cardiopulmonary disease, a soft blood pressure, so one that's less than 100 millimeters of mercury, so that may be in that 90 to 100 millimeter, which is technically normotensive, but not a great pressure for somebody with a PE. And heart rate of greater than 110 beats per minute, and then an oxygen saturation of less than 90%. I'm not going to talk about pathophysiology too much, but suffice it to say that PE, when demise or systemic compromise happens, is all because of RV failure. That is ultimately what causes death and hypotension in PE. And without getting into the weeds on this, basically what we're saying is that when the RV fails, you're below this line and in the category of massive PE, and above that line, physiologically, you're more likely to be in the submassive PE. Okay, so the rest of this talk is going to be focusing on submassive PE. And why do we stratify, just stepping back for a second, it's based on mortality. So massive PE, when you have systemic hypotension, it's not well determined, but and massive PE itself is a spectrum, but it carries somewhere between a 25 and 65% mortality. So it's a very serious disease, as we all know. Low risk, less than 1% mortality. Submassive PE, we used to think had a 10 to 20% mortality risk, but randomized rigorous clinical trials have actually shown a less than 2% mortality in the first 30 days following PE, intermediate risk PE. Actually, I should say 7 days. In the first 7 days following submassive or intermediate risk PE, and a 5% rate of clinical deterioration. And these data come from the PYTHO trial, which was published in 2014, which we'll talk about a little bit more later. So this means that we have very different duties when these patients present. Massive PE, we need to rescue these patients from death. Low risk PE, just immediately anticoagulate these patients and prevent progression to submassive or massive PE, but by preventing further clot from forming. But then this middle category, with those statistics, it's not really that clear if we should be doing something more than anticoagulate these patients, because what are we trying to do? Prevent mortality, prevent hemodynamic deterioration. And what about long-term disability, since I've already mentioned that patients have diminished exercise tolerance, a large minority of them, in the months to years following PE. So focusing on this category, where did this all begin? In the 1990s, several registries were conducted, and this figure in particular actually seemed to launch several trials, and it showed that if patients presented with right ventricular hypokinesis, they seemed to have a higher mortality than those that had no right ventricular hypokinesis in the subsequent 3 months. So several well done randomized clinical trials were conducted, and they all culminated in the PYTHO trial, which was supposed to answer all uncertainty. And to some extent, it did show a positive outcome. So here, what I'm showing is the two randomized groups, the tenecteplase group and the placebo group. And what you can see is the primary outcome happened more commonly in the placebo group than it did in the tenecteplase group. So what drove this difference? It was hemodynamic deterioration, meaning more patients who received placebo decompensated than those who received tenecteplase. So, and there was no difference in death between the two groups. So it would seem like perhaps this is the right thing to do. However, tenecteplase was accompanied by far more major bleeds and hemorrhagic strokes than the placebo group. So all of this led many of us to sort of conclude that systemic thrombolysis, at least for the majority of intermediate risk PE, has a questionable risk-benefit profile. So then, is there another therapy that potentially has the benefits of systemic thrombolysis, but might have a better safety profile? And that's where catheter-directed therapy really took off. And it sort of coincided with some positive trials that were sort of surrogate outcome-driven that made people very excited about this technology. And then, the rapid development of mechanical thrombectomy ensued in the following years, and we are where we are today. But the point I'll make is that it has been a journey through catheter-directed therapy without the rigorous data we need to say that this is something we should routinely do. This is a figure that I think many of us interventionalists show and try to prove that catheters are the way to go. But it should be noted that this was a plastic model, and that was a plastic balloon, and these are particles that were injected into polyurethane. So this is to be taken with a grain of salt. But the idea is that if you have a systemic drug and you have an obstruction in the pulmonary artery, it sort of bounces off of it, forms this eddy current, and goes to the rest of the body and causes all of the problems we associate systemic thrombolytics with in terms of bleeding. In contrast, if you can put a catheter in the middle of what the B stands is a balloon, but really it's supposed to represent a clot. So if you can put a catheter in the middle of that thing and leak out TPA, can it dissolve the clot with less TPA and therefore have a better safety profile? So this particular case could be considered the poster child for catheter-directed thrombolysis. And what you can see here is a right pulmonary artery injection. Actually, it's a main pulmonary artery injection, but you can see the right pulmonary artery has a very large thrombus in it. The left pulmonary artery shows thrombus in its lower lobe branch as well. And this is the placement of two catheters with side holes, and each one is administering about 0.5 milligrams of TPA per hour. And you have that go on for about 20 to 24 hours. And then this is what it looks like. So this is how we used to do it when it came to catheter-directed thrombolysis. And the patient, of course, felt better. The pictures look great. And so why not do this in every case? But beyond that poster child case, there's much more complexity. And I should also mention that the catheter used in that, the Unifuse, is not FDA cleared for specific use to treat pulmonary embolism. Is only used, the indication is for the use of physician-specified fluids, including fibrinolytic drugs, into the periphery, including the pulmonary artery, but not quite going to the point of treating pulmonary embolism. These other two devices, however, do have specific clearances for the treatment of pulmonary embolism, and it's the one in the middle is called the ECOS catheter, and the one to the right is the newest kid on the block. It is the Bashir endovascular catheter. Each one of these have undergone pivotal IDE studies in PE patients specifically, and that has earned them FDA clearance to treat pulmonary embolism. So I'm going to use the term CDL as opposed to CDT when referring to catheter-directed thrombolysis, and CDT as an abbreviation for catheter-directed therapy, which will encompass both CDL and mechanical thrombectomy, or MT. So the umbrella term, CDT, underneath it, CDL and MT. So prospective CDL studies, there have been quite a few, and almost 700 patients have been studied in these trials. Now, I will point out that of them, only the Ultima and Canary trials were actually randomized controlled trials. The rest of these might have been randomized, but not against a control group. What have we learned from these studies? Well, there's really only one graphic we can point to suggest the efficacy of catheter-directed thrombolysis, and that is this one. So basically what this shows is that when you compared the groups, the ECOS catheter is in green and the heparin-only group is in gray. At 24 hours, putting echoes on all of these participants, there were 59 in total, so half got the ECOS, half got the heparin. In the ECOS group, the RV to LV ratio by echocardiography went down statistically. In the ECOS group, it did not change in the heparin group. It should be noted that at 30 days, the heparin group actually did normalize the RV to LV ratio and caught up with the ECOS group. And ultimately, there was no difference in clinical outcomes between the two groups. And really, this is all we can say about catheter-directed thrombolysis or catheter-directed therapy at this point. The Canary trial, without getting into too many details, it is a trial we should all be aware of. It was stopped because of the pandemic, but it enrolled 94 patients in Iran, and it had pretty similar findings to the Ultima, meaning an early signal and a catch-up later in these patients in terms of the RV-LV ratio. Well, what about safety in terms of CDL? I'm sorry, that should say CDL, not CDT. Well, basically what we're honing in on is maybe a 5% major bleed rate and a 0.3 to 0.4% intracranial hemorrhage rate associated with catheter-directed thrombolysis. So it doesn't seem like it's completely harmless. Now, this new kid on the block that I mentioned, the Bashir endovascular catheter, it conducted its pivotal IDE study. It was called the Rescue trial. And in addition to showing pretty good efficacy and very good thrombus reduction and again, this is an association because there was no control group, it also showed a major bleeding rate of less than 1%, which was a very small number and certainly was a hopeful number. But let's keep in mind that only 109 patients were studied in this trial, so we don't really have a point estimate of bleeding with this device yet. It's just it's a promising signal. So all of this technology for catheter-directed lysis still carries this risk of bleeding, which has brought people to sort of bring other catheters into play that don't use fibrinolytic drugs. So you can see all of these technologies here have been developed because of this concern for bleeding associated with catheter-directed thrombolysis. And these are the therapies that I'm going to call mechanical thrombectomy. Two of the devices, the mechanical thrombectomy devices, have actually been trialed in prospective IDE studies and published. And because of those studies, these devices have earned an indication for treatment for PE. The first trial was the FLAIR trial, which trialed the FlowTriever device. The second was the Extract PE trial, which trialed the Indigo aspiration system. So these two devices are actually FDA cleared for treatment of PE based on their positive results, although one can only call it positive by association because there was no control group. So I think I've beat that statement up a lot, but let's reinforce it one more time. Besides Ultima and Canary, CDT trials have not included a control group. So you see all of these trials listed on the left. None of them compared themselves to prompt anticoagulants, close monitoring, or advanced supportive care, or advanced supportive care. So all of these outcomes in the middle, including the RV-LV ratio for these studies, there's no clear answer as to what CDT is doing for them. And then you look down the list and there's some more clinical outcomes that we really need to figure out: death, deterioration, long-term exercise capacity, quality of life in this population. So distilling it into maybe 2 points, why haven't we been able to determine that whether catheter-directed therapy should be routinely used for submassive PE? The first is something we've talked about: the lack of randomization against anticoagulants alone, which is the true control that we care about in submassive PE. And keep in mind that over 1,500 patients have been randomized in systemic lytic trials up to this point. The second is that there's this RV-LV ratio at 24 to 48 hours is, at this point, inadequate as a primary endpoint. We really want to know as a PE community how CDT affects clinical outcomes, both short and long term. The guidelines agree. You look across these guidelines, the AHA guidelines, ESC, SIR, other guidelines from the HCCP, the Anticoagulation Forum, all of their recommendations on CDT are weak, and they really call for rigorous randomized controlled trials to figure out whether we should be, when and in whom we should be using catheter-directed therapy. Well, fortunately, we're in a very different period now, and I think in 5 or 6 years, the guidelines and really the specificity of the recommendations will be much, much better. Currently, there are 4 trials comparing catheter therapy to anticoagulants, and they're all randomized. In the short term, you have the HiPytho trial, the Peerless 2 trial, and the Storm PE trial. Each one of these is sponsored by a different industry company. HiPytho is sponsored by Boston Scientific, and it is a CDL trial only, trialing the EcoSonic device. And I'll show you one slide on the HiPytho trial. Peerless 2 is sponsored by Inari Medical, the same company that conducted the FLAIR trial, and they're looking at their FlowTriever device in something like 1,200 patients. It's just gotten off the ground, and it is a randomized trial looking at short-term outcomes. And the third is a smaller trial conducted by Penumbra called the Storm PE trial, and it's looking at 100 patients, and it is looking at the RV-LV ratio akin to the Ultima trial, but it is a tight little trial and probably should have been one of the first trials conducted. So there is merit there, even though it is using the RV-LV ratio. But the majority of the time left, I'm going to be talking about the PE-TRACT trial. As I'll note in a little bit, PE-TRACT is both a CDL and an MT trial, and it's fundamentally different from these trials in 2 ways. First, it is funded by the NIH. And the second is it's looking at medium to long-term outcomes as opposed to short-term outcomes. Just to backtrack a little bit and describe the HiPytho trial, it is a very important trial going on. It's a global randomized controlled trial looking at the ECOS catheter versus anticoagulants alone. These are its inclusion criteria. Basically, it's intermediate high-risk PE by the ESC guidelines. However, they've enriched this population to look for elevated risk of decompensation. These patients have to have 2 of these 3. I believe UVA is a site for this, so I won't get into too many details there. Obviously, patients with contraindications to thrombolysis are excluded. The primary endpoint is a composite of what you see here, PE-related mortality, recurrence, and clinical deterioration within 7 days post-randomization. So that's where this is a short-term clinical trial. I believe it is an adaptive design, but they're studying up to 406 patients. The follow-up is 1 year, so they are secondarily collecting some longer-term outcomes. But ultimately, what we hope to learn is whether the ECOS catheter CDL results in better short-term clinical outcomes than anticoagulants alone. And it's enrolling quite briskly. Speaking to Stavros Konstantinidis, who's the global PI, my understanding is it's enrolling 20 to 25 patients a month. And that is mostly attributable to the European sites, although I do understand it to have about 10 enrollments per month in the US. Okay, going back to the long term. Well, why should we care about the long-term outcomes in PE patients? Isn't it just an acute disease? Well, it doesn't seem to be the case. So residual thrombus after submassive pulmonary embolism is common. And this is thought to cause increased pulmonary vascular resistance, increased dead space, persistent RV dysfunction. And is this the reason we see some of these associated problems? Increased mortality, increase in CTEPH, functional limitation, which I'll talk about in a little bit, a shortened 6-minute walk distance, reduced quality of life. Susan Kahn in 2017 published her ELOPE study and really shed light physiologically on the fact that these PE patients aren't doing so well. These were all comers, so included many low-risk PE patients. So they were able to assess 86 at 1 year with a cardiopulmonary exercise test. And what they found was nearly 50% had a reduced peak oxygen uptake, which was less than 80% of the predicted value. And that was a number that was much higher than any of us expected. We conducted the systematic review, and these were not of the highest quality, the studies involved. But what we did observe is that NYHA class greater than 2 happened in almost a third of patients, and that is actually fairly preserved in many of these long-term follow-up studies for PE patients. And the 6-minute walk distance, which we aggregated of 415 meters, that's in the 4th percentile. So these patients are not walking as far as they should be in 6 minutes. So really a fundamental question is, if we stop this, or we halt this, or we alter this, can we do better in the long term for these patients in terms of their cardiopulmonary health? And that is where the PE-TRACT trial comes in. In this trial, we're looking at intermediate risk PE by CTA and proximal thrombus, or submassive PE by CTA and proximal thrombus. So an RV-LV ratio greater than 1 and main or lobar thrombus. And these patients are being randomized up to 500, and that up to is because we have an adaptive design incorporated. And they're randomized to either receive catheter-directed therapy with one of the one of the devices that actually have an indication for PE. So that's the ECOS catheter, Bashir catheter, those are the CDL devices, and then the FlowTriever and the Indigo aspiration system, those are the MT devices. So receiving one of those plus anticoagulants or anticoagulants alone. The primary endpoint is 2 primary endpoints. It's not a composite, as you'll see on the next slide. It's actually 2 separate primary endpoints, the peak oxygen uptake at 3 months and the NYHA class at 12 months. The reason for these 2 primary endpoints is we wanted to link a sort of patient-reported or qualitative endpoint, which is the NYHA class. It's what the patients tell us or what the doctor assesses them to be. And we want to correlate that with their actual physiology. So it would be a bit nonsensical if there was a difference in NYHA class if there was no difference in physiology between the groups. So we're actually anchoring the NYHA class to the peak oxygen uptake through a gatekeeping mechanism, meaning we'll only analyze the NYHA class if there's a difference in peak oxygen uptake, meaning the CDT group has a higher peak oxygen uptake than the no CDT group. We see all these other secondary and exploratory endpoints. We're going to get a lot of data from this study. That's probably the most exciting thing about it, but you can see some of them here. We're also examining the short term. So we're looking at a 6-minute walk distance at one year, quality of life throughout the study, thrombus burden, which we'll get into in a little bit, the rate of bleeding in both groups, recurrent VTE, and a very robust health economic analysis, which is all part of our application and now part of our conduct. I'm actually going to skip this slide because it can get into the weeds, but if there's time and interest, I can pull it back up. But it basically describes our interim analyses and how we're going to handle the results we see at each one. So just to give everybody an understanding of what's been happening with PE-TRACT, our first application to the NHLBI actually happened in 2016. We were funded for a planning grant in 2018, 2019, and that's where we switched our primary outcome from the 6-minute walk distance to the one you just saw. And then we applied again in, I believe, 2020 or so, and then finally got funded on our second resubmission in 2022. And that was about June 2022 when we got our notice of award. And then since then, we assembled our team. The first protocol version and informed consent was approved in January of 2023. We activated our first site and did our first site initiation visit in May 2023. In June 2023, the DSMB met for the first time, and that finally cleared us to enroll our first patient in July 2023. Our second site enrolled a patient in 2023, and as of today, May 15th, 2024, I think it's the 15th, 130 patients have been enrolled and 40 sites are activated. So we're off and running and making good progress there. So how am I doing on time? Let me just check real quick. I don't really see a time on this anyway. It doesn't matter. Why is PE-TRACT so important? So I have to point out that it is the only non-industry sponsored randomized clinical trial happening right now. I'm not diminishing the importance of the industry sponsored trials. I think they will generate good data, but the PE community and even those outside of the PE community will look to this one as being the least biased, because truly it is not really motivated to find a device to win. It is motivated to find the correct answer for PE patients. So we have multiple protections against bias throughout the trial. It has true randomization against the gold standard for submassive PE, which is anticoagulants alone, a large sample size, and it's a comprehensive clinical assessment, I hope, as I've demonstrated to you, of CDT, both long and short-term outcomes. So I'm going to take you all on an imagination journey, what the world might look like after PE-TRACT, at least the PE world. One, confidently advising an anxious intermediate risk PE patient. It's always an uncomfortable conversation at this point, unless it's a clear that you're going towards massive PE and we need to treat you. Outside of that, we don't have a lot of data or words to give these patients. The second thing is we will be conducting many exploratory subgroup analyses to hopefully give us signals as to which of these PE patients are best suited or not best suited for catheter-directed therapy. In both groups, we're looking at the RV-LV ratio and PA obstruction at 48 hours, both the CDT group and the no CDT group. So we'll be hopefully able to tell an actual difference between what heparin does and heparin plus CDT does, or whatever anticoagulant is being used at the time, most commonly Lovenox, hopefully. And the second part of that is whether that even matters. So correlating any difference we find between the groups with any difference that we find at 3 months and 12 months. So this cardiopulmonary exercise test we're conducting at 3 months isn't just looking at the peak oxygen uptake. There are many other parameters we're going to be looking at and hopefully getting further funding to really dive into them. But trying to understand the natural history of PE in the patients that have residual thrombus. The health economic analysis is being done by one of the best health economic groups in the country. This is the same group that did the health economic analysis for the ATTRACT trial and is doing it currently for the C-TRACT trial. We are collecting blood biomarkers at baseline and at 3 months to help us understand the natural history of PE and correlate with the response to therapy. While we are not powered to do so, maybe we'll get a signal about which CDT technique has the highest net benefit or may have the best safety and efficacy profile for some subgroup of patients. All of these will be signals that will have to be followed up with further study. But again, that is a pretty exciting part of the study. We definitely hope to give guidance to novel devices and pharmaceuticals in terms of what they should be using as either surrogate markers or as absolute clinical markers. This post-PE syndrome, which has plagued us over the last 5 to 7 years, perhaps we'll be able to define it more precisely and finally, guidelines with level 1 recommendations. The community is large. We have many societal partners. We just had our investigator meeting in Nashville last week, which was very successful and is building quite a community around the trial. So to summarize this 30-minute talk or so, I would say at this point that small RCTs and single-arm studies of CDT have given us signals, but haven't answered the most fundamental questions we need to answer about CDT before proceeding and recommending or not recommending this technology. But we are definitely in the era of randomized trials. And we talked a bit about HI-PEITHO, Peerless 2, and STORM PE. I think that PE-TRACT, and I know this is arguable, but I think it's the most important one for the reasons I cited. And really, ultimately, what we're trying to figure out is this, in the year following PE, is CDT making a difference and benefiting these patients? Thank you very much. That's all I have, and I'm happy to field questions either from the chat or from the group, however, in whatever format people feel.
Professor Sista, that's wonderful. Let's leave this screen and go back to the screen of just us, Jordan. You've certainly given us so many points to discuss. I can think of a bunch of things that I have in mind. There's some questions about trial design from the audience. Andrew, is there something that you wanted to lead on with?
Yeah, fantastic talk, Dr. Sista. I really appreciate it. Dr. Haskal and I have a number of exchanges on this topic, and I've always found them to be fruitful conversations, which don't lead anywhere oftentimes. And I really want to applaud your bold and bald recognition of the limitations of the field. And as a medicine doctor, so much of what I'm taught and rooted in is, does this matter to our patients? And there are unspoken mantras of just because we can do things doesn't necessarily mean that we should do them. And up until this point, the pictures all look good. Up until this point, RV to LV ratio improvements are certainly impressive. But that leaves behind what happens to the patients in 6 to 12 months. We know that 50% of patients will have symptoms at 6 months. We know 25% will have symptoms at 12 months. And what this actually means to us, we don't know. And I'm excited for the end results of this trial because of the fact that it attempts to ask the questions that I can't answer for my patients. Once again, does it matter? And in that regard, that's a very long-winded statement to say, I think this is the trial that we've been waiting for. So to actually get to a pertinent, or actually get to a logical question would be, with all that big, long introduction. I think, how does the trial still address our question about patient selection? Meaning that if you look at the subgroup analysis of any of the trials you throw up, PEITHO, Ultima, any of it, it still comes down to the fact is it seems that there is a patient population that is firmly benefiting from these and ones that are not. And the classic would be the geriatric patient, where we do know that bleeding rates are almost exponential once you cross that threshold. And do you feel that the results of PE-TRACT will be limited in interpretation in the same way as the prior trials as a result of that patient selection issue?
Yeah. So Andrew, first of all, thank you for your words. I don't think they were superfluous. I think they were actually meaningful, and we really did try to design this trial in such a way that it would be really address a fundamental knowledge gap, and that is the medium to long term. So along those lines, I think it's important to note that PE-TRACT won't be able to answer every question when it comes to PE patients. And it's also why I think the industry-sponsored trials are helpful. I think the HI-PEITHO trial will hopefully isolate a set of patients that are more likely to clinically deteriorate in the first 7 days, if they're given heparin alone as opposed to active intervention, and hopefully in a safer way than the systemic thrombolytics that were given in the original PITO trial. So I think from a patient selection standpoint, I'm looking to that trial to sort of fill in a gap that I don't think PE-TRACT will necessarily be able to fill in. We have to see with the results of the trial. We are absolutely collecting short-term outcomes, but I think the population that we're studying with submassive PE, you're going to have a lot more stable submassive PE patients in PE-TRACT than you are in high PITO and potentially in PEERLESS too. As far as patient selection for the actual primary endpoint that PE-TRACT is looking at, it's a difficult question because there's really been no signal as to which patients are more likely to have problems at 3 months and 12 months. It hasn't been correlated with troponin bumps. It hasn't been correlated with the degree of clot. It hasn't been correlated with the absolute value of the RV to LV ratio. And so we're not even stratifying actually to make sure that we have equal groups of any of these because there hasn't been a scientific reason to do so. So I'm hopeful that there will be a signal that comes out of this because we study enough patients. I think it's different than the DVT world, in which there was already a hunch that iliofemoral DVT was going to be more effective. Catheters were going to be more effective for that, but we had to study that many patients for several reasons. What also made it difficult to get funding in the first place was just there was so little preliminary data about this post-PE syndrome and in terms of risk stratification and patient selection and even outcomes in this arena. So it is a big, bold, bald question. And I think it's going to take a little bit of luck and a whole lot of analysis to see if we can get specific about which patients are most benefit from CDT.
You pointed out the challenge, the upside of this type of trial, which is akin to ATTRACT in the sense that it was a multi-modality but high-level, essentially independent of industry trial, trying to answer a fundamental question, which is, are we going to improve a leg by performing a lysis versus anticoagulation? And in that sense, there's similarities to me, oversimplifying, compared to kind of the lean and mean industry trial that does a very highly focused design trial around one device designed to show positivity for that device. You talked about, for example, the ECOS versus heparin, the Ultima trial. None of them compared to sort of drip thrombolysis off-label for infusion catheter, because there might or might not have been a difference. That's of no interest to somebody designing a catheter to show that you're in fact no better than another form of drip, but only to anticoagulation. So we have this sort of two parallel channels. And the upside are everything that you said. The challenge is going to be that it has to, by nature, look at catheter intervention as an almost homogeneous approach by having all these different things housed in it and hoping that you'll be able to power individual outcomes. How worried are you that heterogeneity may, in fact, make it tough, not give you extra signal?
Yeah, it's something we've spent a long time debating. This PE-TRACT was originally a catheter-directed lysis trial, and the reality is it took many years to get it funded. And over the course of that time, the field changed. And it changed in a direction that modern PE practice was 50% lysis and 50% mechanical thrombectomy. And for whatever reason, we all know many of the reasons, but mechanical thrombectomy really gained a lot of popularity, and the incentives were financial. There was, you didn't have to drip somebody in the ICU. We all know the reasons for this. So, I completely agree with you that everybody scratches their head to say that the two techniques are exactly the same. That could be considered a stretch. Now, at the same time, nobody's conducted the study to see if they're the same or if they're different. And then there's the reality of conducting a clinical trial. If we were only a catheter-directed thrombolysis trial, we would not be able to enroll nearly as many sites and as many patients. Yet if we were only a mechanical thrombectomy trial, that would also leave out some important. So ultimately, you know, in order to maximize the number of sites, to maximize the number of participants, we've chosen this strategy of CDT or no CDT. And it's as practical as it is, you know, I think its greatest defense is that there hasn't been anybody to come around and prove that there is a difference between the two, even though each of us has our inkling that they may not be the same.
It may be worth giving some people a bit of a flavor of the challenge, you know, which is you see somebody relatively young who gets classified as submassive in her 30s, who gets anticoagulation, and then you might see them in your clinic, you know, 3 months later, for whatever reason, for another condition, and you can elicit a story, which is she has trouble climbing 2 flights of stairs to her office. And that's a fundamental and debilitating residua of a PE that would otherwise 99.9% be treated by anticoagulation. And how many of them will be like her, a very real event versus not, the point that Andrew's made. And you know, these are real human questions that we're seeing on the back end that you're going to address. We have a question from Professor Matsumoto asking about RVN diastolic pressures and why that wasn't a piece of this.
It is. So we are measuring hemodynamics during the actual procedure. We're asking sites to do this, and we are asking them to measure cardiac index. It's not required because this is a real world modern PE practice kind of trial, and you know, burden on sites is something that we're very keen, and we have already had pushback from several sites who say this is adding too much to the procedure, but we are trying to collect as much hemodynamic data as we can, and the cardiac index
there's a limit
feel
to not having protocol deviations.
Correct.
With a large number of enrollments.
Yeah. So, but we are trying. I didn't list every single thing that we were doing, but we are trying to get on-table hemodynamics both pre and post.
We had a comment from Professor Durdane, who was talking about your interesting use of 2 endpoints, and that even if only peak VO2 at 3 months is positive, that could still be pretty impactful and a pretty positive outcome for that data alone.
Yes, and that it would be considered a positive trial. A priori, we laid out the scenarios. If peak oxygen uptake is positive, the trial is positive. If peak oxygen uptake and NYHA class is positive in CDT's favor, then obviously the trial is positive. The trial is negative if peak oxygen uptake is no different between the 2 groups.
Yeah, there's a real efficiency to that. So what are you doing now in patients who don't enroll, who are elderly, where you have real concerns about potential senile angiopathy and risks of lysis, and they're in that middle ground, and they're not getting into the trial?
Well, you know,
yeah,
that
exactly. That's the reaction right there.
I mean, I pick it to the pert to do their good work.
We call it Andrew or Aditya Sharma as well, who's online.
Yeah, give them that headache.
A good word thanking you for leading this enormous trial.
Yeah, I saw that. Thank you, Aditya.
Dr. Sista, so this may be going into nuts and bolts. Are you collecting other data from your CPET, meaning that from the pulmonary side, you know, one of the cardinal features for vascular limitation to exercise is actually the inappropriate dead space response that you see. And I would say from our literature in terms of the CTED and CTEF patients, that is the one that kind of gets the concluding sentence on your abstract and sticks out more and more. So VO2 max, I think is an interesting endpoint. I'll tell you right now, it's the big sexy out in the community, right? Everybody's concerned about pushing their VO2 max in the fitness TikTok world. But in terms of how it translates into the limited data that we have for these patient populations, sometimes it may not be the best. And so, and it's not, I know you spent a ton of time setting this whole trial up, and I'm not trying to snark on it or editorialize it, but it'll be interesting to see in your subgroup analysis for some of these secondary things. I do wonder if they will have a bigger weight than may is anticipated in what's set up as a primary endpoint there.
Yeah. So again, I'll go back to the reality and of the application. Some of the more physiologically specific, for lack of a better term, CPET parameters, they didn't have the gravitas of peak oxygen uptake, meaning their associations with hospitalizations, association with mortality, just weren't there. They hadn't been, not that they don't exist, just that they haven't been studied that way. And as opposed to the pulmonary hypertension groups and the heart failure groups, which the peak oxygen uptake had a very clear correlation with rehospitalizations, mortality, and correlations with NYHA class and whatever class of heart failure you want to use. So from a practical standpoint, we had to use that as the primary endpoint if we were going to use cardiopulmonary exercise testing. But Tim Morris is on our steering committee, and he's very into the dead space issue and very into his 4 quadrants of, correlating dead space and cardiac output and putting patients in those quadrants. And we are that is actually probably the most interesting part of the CPET from my standpoint. Obviously, we're going to be reporting on the peak oxygen uptake, and that'll be positive versus, but again, we're looking for any signal that tells us something about the natural history of PE and whether the CDT does anything. And so those parameters that you're discussing, and I have to say, I've read the ATS documents several times. I still need to, get up to speed, and hopefully when we write this next application, I'll become more of an expert. And I'm a little bit shy and embarrassed to try to even say anything in front of you, Andrew. But needless to say, we do have good guidance from pulmonologists in terms of the other CPET parameters we'll be collecting, and we hope to have very meaningful data, physiologic data, beyond the peak oxygen uptake.
So we're coming up to the top of the hour. A quick question: is there going to be an interim analysis, and is that built into the powering for a data break to look for differences, or you run all the way to the end?
I'll say it one more time, Ziva. I was looking at some of these comments.
Are you? Is there an interim analysis in which the randomization is broken, and when might that happen? Or
yeah. So that was that one slide that I skipped over for time's sake. But basically, the first interim analysis will happen at 250 patients, and it's basically at the time, if the probability that the peak oxygen uptake at the full 500 is greater than 95%, we would stop the trial for efficacy. If it's less than 5% likelihood that that it will be a positive result, we would stop for futility. And then as far as NYHA class, we would bake it in there. But if there was not enough information about the NYHA class at the interim analysis, we would continue the trial.
Thank you. Well,
and the interim analysis would happen every 50 patients, so 250, 300, 350, 400, 450, up to 500 patients. And we anticipate, from a probability standpoint, because we did a lot of trial simulations, that the trial will likely go to between 380 and 420 patients.
I'm struck perhaps by the long perspective of where this was when I started my career, which is now quite some time ago, where we would essentially beg and plead to do any sort of catheter-directed intervention for massive PE. And we were told consistently by pulmonologists that there's no evidence that local lysis has any effect, and it's an abomination to consider. Until we started to see, for example, ultrasound-activated infusions of lysis that essentially began to pivot away from anything other than systemic or nothing, to the point where we can ask these fundamentally difficult and yet essential questions that you're tackling with large numbers. It really is an astonishing evolution over 3 decades. I want to thank you so much for taking the time this evening to share this exciting trial and how much you've already enrolled in it and this unique design, and also to Professor Mihalich for joining us as well and providing perspective. We're excited to see data releases as it comes along. Thank you so much, and thank you for joining us tonight on the UVA Keynote.